Because this is a female, the next step will be to express Sally's bladder, and we can do this in lateral or dorsal recumbency using gentle constant pressure to squeeze her bladder in a caudal direction to express the urine into a container. This is done in order to prevent urine scald, soaking of the patient or the surgery table, and which will chill the patient and then prevent contamination of the surgical site and to keep the bladder out of the way because this is an abdominal surgery. But expressing the bladder can be contraindicated, such as cases of cystotomy, pyometra, and if there are any reasons for abdominal trauma. Now it's time to surgically prep the skin. We cannot sterilize the skin, but it is important to reduce the contamination in order to reduce our risk of infection. So pretending that this is my surgical site, I'm going to use gauze that is soaked in chlorhexidine and gauze that is soaked in alcohol to scrub the clipped surgical site using a target pattern. So we're going to begin at the proposed incision site on the midline, caudal to the umbilicus, and we are going to wipe gently in a clockwise pattern, slightly overlapping with each circle getting bigger. We always want to keep the outside towards the outer edge along the hair in order to keep the contamination from coming inward. And then once we get to the hairline, we're going to get rid of this one, and then we're going to switch to our alcohol, and we are going to do the same thing in the same pattern. So once we have done this with chlorhexidine and then alcohol, we are going to repeat this process for a total of 3 times. Dirty scrub has been completed. The patient is ready to be moved into the surgical suite, so we are going to unhook her from the current anesthesia machine and gently carry her into the surgical suite where she'll be reconnected to the anesthesia machine in the surgical suite that has already been prepped, as well as connected to all of our monitoring equipment. And because she is a small beagle mix, we have also set up a hot dog for her to be placed on in order to keep her body temperature up during the procedure. The patient's going to be placed in dorsal recumbency and properly secure the patient to the table to not only aid in aseptic preparation of the surgical site, but to also ensure that the surgeon has an immobile patient with adequate room to work. So the hind legs are going to be tied straight back to avoid stressing of the stifle joints, and the front legs are either pulled straight forward or crossed. And these legs are going to be tied using half hitches twice on each leg, so one will be above the tarsus or carpus and one will be below the tarsus or carpus on all legs except for the one with the catheter, because we do not want to occlude the vein. So once these half hitches have been tied, they are going to be pulled straight back and hooked on the table hooks. I'm going to demonstrate how we would apply the half hitches to our patient's leg. So the first one will go above her tarsus, and then our next one will go below the tarsus, creating 2 half hitches. Then her leg can be pulled straight back and tied to the table hooks. Now that our patient is properly positioned, the surgical scrub must be done. So this is the final scrub, and it is always done using designated scrub and alcohol that is from the surgical suite, and the scrub is done in the same manner as before using the target pattern. So opening the sterile containers with the soap gauze, and you want to transfer the gauze into one hand, designating one a clean hand and one a dirty hand, and then the dirty hand will be the one that is used to scrub the patient, while the clean hand is the one that's always used to grab the new gauze out of the container without causing any contamination. The final step is to paint the surgical site with an iodine at the incision site and let it remain there and dry. So you want to spray the first squirt into a trash can to remove any of the debris or bacteria that can be in the spray nozzle, and then with a swiping motion, just apply a light mist to the incision site and let it dry. In order to perform jugular venipuncture, I'm going to need all of my appropriate supplies, including a 20 gauge needle, a 1 ml syringe, alcohol, cotton or gauze, and an EDTA blood tube. So for this procedure, I'm going to open my syringe and needle, sterilely put them together, and I'm going to make sure that I break the seal on my syringe before being in the vein to prevent any collapsing. And then I'm going to hold off the vein at the thoracic inlet. I'm going to visualize where the vein is, and I'm going to palpate to find it. And then I'm going to apply my alcohol on the vein, and I'm going to use the side of my thumb to pull the skin taut without touching the vein again. And I'm going to poke this through the skin with a good poke, introducing the needle with the bevel up, and if I'm not in the vein immediately, I'm going to slowly aspirate on the syringe while redirecting until I get a flashback of blood. And then once I'm in the vein, I can collect my sample by gently drawing back on the syringe and letting go and allowing the blood to fill the syringe. So after it's collected, I'm going to take my needle out and I'm going to hold the gauze on the site, applying steady pressure to prevent a hematoma formation. And then I'm going to transfer my blood into a blood tube properly, and I'm going to label this with the patient's name, the date, the species, and my initials. After the surgery has been completed, as the GCN or the SA, I'm going to make sure that nothing is missing from this procedure. So I'm going to count all of my instruments, including the gauze, until everything has been accounted for. If any additional sterile gauze has been added during the surgery, I want to make sure that I account for this as well before the patient is woken up or fully closed, in case any gauze or instruments have been left inside the patient. Also, at this time, all of the leads from my monitoring equipment can be untied and the anesthetist can begin to wake up our patient. Now, as the anesthetist, I'm going to take over my post-op recovery for this patient. So this begins with the cessation of anesthesia and ends with the patient's vitals returning to normal. So the recovery plan begins with first turning off my anesthetic vaporizer, and I will leave my patient on just oxygen for 5 minutes. At this time, I'm going to deflate my ET cuff fully, and I'm going to untie my ET tube. I'm going to check all of my patient's vitals, including the temperature, the pulse, and respirations, as well as check my patient's reflexes. So after 5 minutes of oxygen, I'm going to disconnect my patient from the anesthesia machine and then turn off the flow meter. I'm also going to recheck my patient's vitals at this time, and I'm only going to extubate once my patient has either swallowed 3 times or is beginning to pick up her head and coughing, because we don't want her to chew on the ET tube. I'm also going to continue to monitor my patient's vitals until they're normal. Her temperature must be above 98 degrees before being returned to her recovery cage, and at this time her temperature is 99.5 degrees, so she is returned to her recovery cage, but I must continue to monitor her vitals for at least 5 to 10 minutes, or as long as it takes until they are normal again. This may even take hours. So a normal canine's vitals include temperature 100 to 102.5. Her pulse should be between 60 and 180 beats per minute, and respiration should be between 10 to 30 rests per minute. I'm also going to provide extra blankets to continue to increase her body temperature, and I'm going to keep her as comfortable as possible during her recovery procedure. And following this anesthetic protocol, Sally will receive Onsior by mouth every 24 hours for 3 days, and her first dose she will receive 24 hours from now, because she has already received her sub-Q dose of Onsior prior to her anesthetic procedure. Sally has now undergone her spay procedure and is beginning to make a full recovery with no complications. Overview of Sally's anesthetic procedure. She received acepromazine, atropine, and buprenorphine as her pre-medication, semi-membranosus and semi-tendinosus. She was induced with propofol and given sub-Q Onsior as her pain medication. She was maintained with isoflurane. She had a 1 liter rebreather bag. She was maintained on 1.5 liters per minute of O2. We used a 7mm ET tube. She was also using a rebreathing system. We put a saphenous catheter in. She received 57 milliliters of fluid during her procedure, and we also monitored her procedure using manual ECG, pulse ox Doppler, and an esophageal stethoscope. Her sutures were closed with 2-aught PDS. Her post-op recovery was 99.5 degrees. Her overall surgery took 30 minutes. She was extubated at 9:30 a.m. and she was sternal at 9:35 a.m.